Dr. Yahya Kiwan, Dr. Sahar Qazzaz, please join us. Huh? Yes, we have it. Dr. Abdul Majid Alwan, please. So I will invite Dr. Maher for the first keynote speech entitled Advances in Laboratory Medicine in the Era of AI. Please come in.
Double click. Ladies and gentlemen, حضرات الحضور الكرام، أقدم شكري إلى منظمي المؤتمر، بالأخص إلى الدكتورة مريم مطر لجهودها الحثيثة في قامة هذا المؤتمر الناجح، وكذلك الأخ الدكتور يحيى كيوان رئيس اللجنة العلمية على دعوته الكريمة. Yes, I think it's better now. I'm Maher Hilali. I'm a hematologist and a lab director with Medical Clinic Group in the Middle East. What I'm going to talk about today is advances in lab medicine in the era of artificial intelligence and AI. Health service provision is changing. There are huge opportunities and technology drivers that are employed or deployed to use them. We use a lot of techniques that are currently used to monitor laboratory status of a patient, including wearables, use of the internet, probes, and other near-patient testing machines. In addition to that, there are great opportunities in terms of the internet deployment, use of the cloud, and machine learning and artificial intelligence. Sorry. I think it's stuck, this one. Yeah, here. Yes, it's working now.
Okay, just double check.
Yes, yeah, direction there. There are a lot of transforming technologies that we can deploy that is really will shape the future of lab service. The first one, as I mentioned, is AI and machine learning. The second one is the deployment of point-of-care testing and wearable technology, in addition to automation and robotics in lab medicine, and an advancement in molecular and genomic testing. AI application has been deployed very effectively in different parts of the health sector. One of the things that we use is we can use AI applications in the diagnosis and analysis of patient data and population health management and predictive care guidance and effectiveness and management of patient and reduction in physician errors and in medical imaging in addition to diagnostic and healthcare. So that's the first arm that we use artificial intelligence. The second, we can use also to engage with patient quite effectively. Things like, diet guidance, predictive modeling, interactive booths, wearable integration, virtual personal assistance, and personalized activity coaching has all been deployed to engage with our patients using AI. And there are a lot of apps and a lot of programs that will promote that. The third aspect is improving of the workflow. And we can do that through elimination of unnecessary steps and dealing with physicians and advising them how to use laboratory tests. We can use it to support our supply chain and procurement, in addition to solving issues with the staff management and network coordination. If I look at the lab now is basically, we have a patient that uses clinic, uses hospitals, and interact directly with them. In the future, the patient is going to be in the center of everything. The patient can actually be seen virtually through AI, through an apps, telemedicine. He can order drugs, lab tests, pharmacy, even radiology can be deployed for the patient care. And this is being facilitated through artificial intelligence and machine learning. There are, however, problems into deployment of artificial intelligence and machine learning. The first one is that we have to comply by regulations and regulatory authorities. The second one, there is a big issue with data privacy and cybersecurity, and bridging the skill gap in technology between the current one and the future. I will say that the main changes over the next 10 years within the lab service includes, first of all, the deployment of AI, validation of the AI results, and ensure machine learning. Automation is already there, but we are going to improve on it and do a little bit more. Advanced diagnostic. The biggest diagnostic advances is in next generation sequencing and molecular genetics. CRISPR technology will do the same. Precision medicine is now a fact of life. Now we design treatment per patient. There is no one solution fit it all. There is now a designer treatment for every patient based on the clinical status. Point of care testing is now expanding. Currently, we do about 10% of tests nearer to patient. Things like a glucose, blood gases, HbA1c can be done near the patient, but these tests are expanding. The last thing is in data security. As we get more and more expert in machine learning and AI, we can then deploy these appropriately. Well, I will start with just an overview of what we have done recently. The first one, I'll go into the era of digital pathology. Normally, pathology is that we do a slide of the tissue, and then the doctor will look at the microscope, report it, and write it into a report, into that. Nowadays, this slide can be scanned using a scanner, and we can do up to 200 slides or 240 per session, and this will be ready for the doctor to look at the computer and see them. And by looking at the doctor, looking at the microscope plus the computer, there will be the process of machine learning where the doctor will actually interpret and add the data to the computer that will be registered. The collective learning or teaching of the doctor to the computer, the pathologist to the computer, will generate an AI-driven report. This is possible now also in cytology. Cervical cytology, we have got two techniques. One is called SurePath, and the other one is ThinPrep. The ThinPrep technique is now possible for the computer to scan the slide and identify areas. You know, if you look into the last slide, you can identify, this is the process. The slide is taken, scanned, and then the doctor will report it. And this is the way that the doctor look at the report, and the computer, what the computer or the AI do is identify area suspicious of disease, such as cancer, and instead of the doctor just going through the slide for 20 minutes, 30 minutes, the AI will identify the area for the doctor in about less than 2 minutes, and the doctor will give an opinion into that. So the efficiency of reporting can be significantly improved using AI. This is the ThinPrep in cytology. As you see, this is the round thing, circle, is the cells in this slide. And these are the picture generated by AI to show you the abnormal cells at higher magnification. This will reduce the screening time of a slide from 10 minutes to about 3 minutes, a significant efficiency and accuracy of the test. Other thing that we can do is basically the benefit of digital pathology is to improve report precision, reduce reporting time, and improve productivity. And this is well known now. If we go from histopathology and cytology to clinical microbiology, we can talk about something called moldy TOF. Microbiology, what we do, we take a swab, and then we culture it. And once it is cultured, we'll wait for about 24 hours for the culture to be positive. Then we will try to identify the bacteria and identify sensitivity. Nowadays, instead of waiting for 24 hours, the bacteria can actually be put on a machine supported by AI and machine learning called MoldyTOF using laser technology, and it will read peaks of proteins on the surface of the bacteria and identify the species. So instead of waiting for 24 hours, we can do the report in 6 hours. This has significantly changed the microbiology and the identification of bacteria using this technique. Another thing which is quite amazing, really, and happening is molecular biology. The combination of molecular biology and microbiology gave us a science of metagenomics. So what we can do is that we can look at the bacteria in a different way. The traditional way of looking at bacteria is basically to look at the culture. That's in the first picture. The second picture is the consultant will recognize the type of bacteria there under a microscope. And this is a morphological examination. These are very basic, and it takes time. By using immunological tests, using antibody against certain type of bacteria and viruses and fungi, we can deploy, and this is a little bit more accurate and also quicker than the culture and morphology. Nowadays, we can use techniques like RT-PCR, things like COVID testing, to detect certain genes that represent bacteria type or virus type or fungi. And this is basically an RT-PCR technology. The latest one that we are doing is metagenomics. We can look into the gene of the bacteria and identify the name of the bacteria, viruses, and fungi based on their gene constituents. There are two types of metagenomics. One, looking at the type. The other one, look at the type and behavior. So we can identify if there are any antibiotic resistance or anything similar to that. If you look into that, nowadays in microbiology, we can only culture about 7,000 type of bacteria. But by doing metagenomic, we can identify up to 27,500 bacteria, viruses, fungi, and chlamydia, and others. And all these are available in metagenomics testing. The majority of these bacteria are beneficial bacteria. Only less than 2% are pathogenic. And only 29% of these microbes can be detected using the traditional microbiology technique. So from now onward, metagenomics is going to replace microbiology and molecular biology. This is another activity with molecular biology using certain syndromic testing. This is again as a gene testing, and we can separate different group of tests. So for example, we can identify the influenza group versus the other viruses versus the bacterial infection. It is particularly useful for patients admitted to intensive care unit where treatment will need to be started almost immediately because of the seriousness of the condition. And this can be done easily nowadays using RT-PCR technology. Molecular genetic and precision medicine. Another field that has actually improved and is going to continue to improve is our understanding of molecular biology. We can test not only the DNA and the sequences, we can also look at the RNA, we can look at the genes constituting there. We'll use molecular genetics to screen, diagnose, give a predictive testing, in addition to ancestry. And we can use that
3 minutes left. Sorry.
3 minutes? Or time? I'll have 2 minutes, okay? In molecular genetics, we can look at the chromosome, and this is cytogenetic testing. But at the same time, the chromosomes will give us translocation. If we take it further, we can deploy this molecular genetics into the precision medicine. This is an example of application of precision medicine whereby we identify the Philadelphia chromosome, which is a chromosome present in chronic myeloid leukemia. And from that chromosome, we identify the mutated chromosome, the deleted chromosome, which is BCR-ABL mutation. And this will give us a protein. This protein occupies a receptor on the myeloid cells, and the myeloid cells start reproducing without stopping. By identifying a molecule similar to that, but inert, the receptor can be occupied by this ST579. And this molecule will inhibit the myeloid proliferation and almost cure chronic myeloid leukemia. This is the first example of precision medicine done by hematologists in the 80s of last century. The last advancement I can see is basically the use of mass spec. Mass spectrophotometry used to be a very expensive and very special field of chemistry. Nowadays, there are a new generation of mass spec that you can integrate into the chemistry platforms, and this will give you very high caliber, accurate assays for hormones, for proteins, and can be deployed for trace metal analysis in addition to various forms of proteomics, polypeptidomics, and other omics. These are the range of tests that are currently available on the mass spec, and this can go, is expanding. I think the last advances in analyzers has been also progressing. Nowadays, you can actually do a full hematology analyzer on a small handheld machine with a chip that uses microfluids technology to give you the latest results. And there are other techniques such as the magnetic MRI for microscopes, and this will give you the MRI of a molecule. And you can actually report results not only based on the MRI picture, but on the pathology within the cell or the tissue. Thank you very much.
Thank you very much, Dr. Maher. Because you're engaged in another workshop right now, and the fourth level for whoever would like to attend, we are glad to present you with the certificate of appreciation for your wonderful talk. Thank you.
Fantastic talk. Thank you very much. Thank you for
It is my pleasure. It is my pleasure now to introduce you to our next distinguished speaker, Professor Yahya Kiwan, Senior Consultant of Invasive Cardiology at Suleiman Habib Hospital and a pioneer in the regenerative medicine. He holds the fellowship of the American Board of Regenerative Medicine and has actually initiated a special board for cardiology in regenerative medicine. So it is my pleasure to invite you to the stage and talk about innovations of regenerative medicine in subspecialties. Please, Dr. Yahya.
I just have a special announcement. The scientific committee, they gave me incentives of 15 minutes extra. Thank you very much for that. So my presentation will be half an hour. And I just want to welcome my wife. She's sitting there. She came specifically to take some pictures. This is a joke, but please give me time. I'm here. I am interventionist cardiologist. I am the pioneer of intervention in Dubai in 1995. Today I will talk about general. So I would love to see the audience. They are general physician with all the subspecialties in medicine. One comment, don't start the time, please. Allah khalis. I haven't started yet. Okay. The reason I'm showing this picture, because this picture I took after 3 injections of intravenous stem cell therapy, and I look 15 years younger. That's my wife has told me that. Now, we talk about regenerative medicine, and it's a very confusing topic, but I just wanted to tell you the definition of regenerative medicine. Regenerative medicine involve or include, I didn't do that, but yeah. Stem cell therapy is one of the types of regenerative medicine, tissue engineering, another, immunotherapy, Dr. Maher has talked about it, gene therapy, biomaterial, and regenerative pharmacology, all involve regenerative medicine. Now, regenerative medicine, many people, when I talk, they said it's not approved, it's still experimental. It is not. Honestly, these are the literature which I showed you, the application. There are more than 11,000 trials on general medicine, I mean all specialty. In cardiology, we have more than 800 publications in regenerative medicine. These are the list of regenerative medicine. The musculoskeletal is the highest, cardiovascular number 2, neurology number 3, and unfortunately, I think Dr. Sahar will be angry. I think plastic surgery and rejuvenation is also on the top. So these are the evidence. Now, I just want everybody, again, when you talk to him, said, it's not FDA approved, but it is wrong, or is not true. We have 24 cellular and gene therapy products approved already by the FDA. The problem with stem cell therapy, we need to get approval of each medical condition and each product. That's why we need hundreds and hundreds of FDA approval. It's not like aspirin or whatever antihypertensive medication. So these are 24 from FDA. Now, what are the types of approvals we have? We have approval in cell therapy, cancer. Dr. Maher has left. Dr. Maher has been using stem cell therapy, which is bone marrow transplantation, more than 50 years ago, or maybe 60. He used it in 1982. So this is stem cell therapy, leukemia, lymphoma, myeloma, and other solid cancers. Genetic disease, gene therapy is a regenerative medicine. And these are approved by the FDA in the treatment of neurological conditions, blood conditions, sickle cell, hemophilia, melanoma, solid bladder cancer, and so on. Now, stem cell therapy approved in the following countries. Stem cell therapy approved in South Korea, in Japan, in Europe, United States, India, Iran, and China. There is approval, and you could see approved since long time. They're like 2012, 2011, approved in certain conditions. And I want to mention here, since 2011, it was approved in acute myocardial infarction in South Korea. Now, tissue engineering, this is a newly published publication. This is an artificial vessels created by tissue engineering, replacing any conduit. And this is the trial on that, just published a month ago and approved by the FDA. Now, you can start counting the time from now, because this is my lecture start. Now, what I'm going to talk is evidence-based medicine. Now, in any branch of medicine, we follow guidelines. And in the guidelines, we have an evidence level 1, level 2, level 3, and level 4. And the definition of each level comes from this is the level of evidence from Oxford Center for Evidence-Based Medicine Guidelines. And they get level 1, 2, 3 according to the weight of the clinical trial. Is it large randomized clinical trial? Is it meta-analysis of multiple randomized control trial? Is it regional or personal studies, and so on? So these are evidence-based. So when I mention level 1, the definition is there. It's not from my pocket. And this is the level evidence. So level 1, therapy prevention is systemic review with homogeneity of randomized control trial. We give it high level 1 and so on. Because I'm rushing, Okay, so let's go with evidence. Now we start with osteoarthritis, which is musculoskeletal disease. And you could see how they create the evidence. This is the study subject, whether what topic like osteoarthritis. This is the years of publication. The publication from 2016 up to 2023. So most of them, they are recently published meta-analysis of randomized controlled trial. And these are the type of study, meta-analysis, the level of evidence. And this is the most important, and the conclusion. So because of the sake of the time, I will rush and show you the evidence. In osteoarthritis, all the level of evidence, level 1, level 1, level 1, and some of them level 2. Level 2 is a different definition, but that's a good evidence. Now, talking about plastic and cosmetic surgery, Dr. Sahar will talk about that. We have strong evidence in plastic and dermatology. Again, the publication very recent, and the level of evidence, level 1, level 1, level 1, in each condition, which include in burn, wound healing, and other condition, whether using PRP or stem cell or fat grafting. Again, we're talking about scars and aging skin. This is the topic of Dr. Sahar. But again, the evidence in the literature, there is level 3. Level 3 means the study are very limited and they cannot conclude enough number. So level 3. But most of the levels of in scars and aging skin is level 1. Now, talking about neuroregenerative or neurodegenerative disease, again, the 3 conditions which I'm going to touch, stroke, spinal cord injury, and cerebral palsies. These are chronic, incurable neurological diseases. Look at the level of evidence by using stem cell therapy. Level 1 in stroke, level 1 spinal cord injury, and level 1 in cerebral palsy. This is my specialty in cardiology. I have a very distinguished friend sitting there. Yeah, he's a cardiologist coming from UK. And when I said hello to him, I am regenerative specialist. He said, Dr. Yahya, but regenerative cardiology is not approved. I said, my friend, come with me and have a look. This is the evidence, doctor, in cardiology. This is in stem cell in angina, stem cell myocardial infarction, and stem cell in heart failure. Level of evidence, level 1, level 1, level 1, level 1, level 1. And these are the conclusion. Improvement in left ventricular function, removed from the cardiac transplant list, and increased survival. Again, this is heart failure. I have no time. Fatma, please give me time because I have to rush. Pulmonary condition, we have very good evidence during COVID, and the level of evidence in COVID ranging between level 1 and level 3. Endocrine, we have so many distinguished endocrinologists here, and we have very strong evidence of stem cell therapy in treating type 1 and type 2 diabetes. Level of evidence 1 in both type, more so in type 1 diabetes. Now, this is where please give me time. This is another evidence. There is an interventional cardiologist. He's a German living in America doing stem cell therapy for more than 25 years. In general, he does everything plus intervention. So what he came in his book, this book called The Secret World of Stem Cell Therapy. And what he divided the results into stars. So if it is good result, he called it 5 stars, and 4 stars, and 3 stars, and 2 stars. And the meaning of 5 stars means every single patient treated with a stem cell has improvement. 4 star, most of the patients, they get improvement, and 3 star, more than 50%. So all showed good evidence from a score of 5 star, 4 star, and 3 star. So let's go through the condition quickly. Fatima, please, I know, but just give me time. Now, in heart failure, doctor...
Yeah, you have 3 minutes, Dr. Yahya.
Good?
Thank you.
Huh?
3 minutes?
3. Okay. خليها 5. لأنه تعرفين دكتور محمد جميلي ما جاي والله. يا دكتور والله تعبت، صار لي 4 أشهر على هذا المؤتمر.
Your
والله حرام
presentation
عليك.
is amazing. Doctor.
Okay, heart failure, it is 4 star. The result of treatment in heart failure, 4 star. Coronary artery disease, 4 star. Peripheral vascular disease, 5 stars. Erectile dysfunction for urologist, 5 stars. Dr. Manaf, yeah. And facial rejuvenation, any dermatologist here, 5 stars evidence. Neurodegenerative disease, 4 stars. And degenerative joint disease, 5 stars. Back pain, 4 stars. This is a book called The Death of the Death. This is just published last year by 2 genetic engineers. And what they suggested that death will be optional and aging curable by 2045. I think. خلصت؟ لا بعدني. This is my retirement with Dr. Hilali, who left from here. We decided to open a stem cell cafe in Jumeirah. And if anybody interested and have good money, please join me. Thank you very much, and sorry to get long.
Thank you. Thanks again, Dr. Yahya Kiwan, for the amazing overview of the importance and the applicability and the efficacy of stem cells and regenerative medicine in the different subspecialties. Thank you again. I have the pleasure now to introduce you to Dr. Abdelmajid Alwan. He's a senior consultant hematologist and a fellow of the Royal College of Physicians. He's a pioneer in the stem cell field in Iraq, and it is our pleasure to have him with us from Iraq and to talk about regenerative medicine in Iraq. تفضل. The floor is yours.
شكرا جزيلا. شكرا دكتور يحيى على الدعوة، دكتورة مريم، دكتور مناف. So we start. حقيقة أنا يعني اختصاصي هو أمراض الدم، فمشتغل يعني في مجال الباطنية أمراض الدم، وسوينا أول عملية زراعة نخاع العظم. المشكلة صارت قبل دخول الأمريكان 24/1/23 أول ألوجينيك ترانسبلانت بالعراق، وبعدين اشتغلنا أوتولوجاس إلى آخره. بعدين دخلنا بالفيلد الجديد اللي هو ريجنريتيف ميديسن، واللي يستخدم الهيماتوبويتيك والنون هيماتوبويتيك فور اذر ديزيزز اذر ذان بلاد ديزيزز. فوصلنا الى حد انه احنا سوينا فريق عمل داخل البلد، وصار انتجريشن ويا البين مانجمنت بطريقه مذهله انه نحصل نتائج مهمه مثل ما ذكر دكتور يحيى، يعني 5 ستار و4 ستار خصوصا بالاورثوبيولوجيكس. فاني ودكتور خليل جمعة اللي هو موجود هنا بالقاعة سوينا شغل جديد هذا خلال السنوات الأخيرة. بالنسبة أيضا أخذنا يعني البورد الأمريكي we are the affiliates، وسوينا دورات. الدورة الأولى للبورد الأمريكي، الدورة الجاية في الشهر القادم داخل العراق لأطباء، وهذا الكلام ده يحكي كريس باولوس اللي هو رئيس البورد الأمريكي. طبعا احنا تعريف ريجنريتيف ميديسن ما ندخل به التفاصيل هذه. بالنسبه للتكنيك اللي عندنا بالعراق، عندنا البريفرال بلاد هارفست. اول واحد يعني ناخذ من الدم المحيطي ونجمع الخلايا الجذعيه، طبعا ممكن من النخاع، من الدهون، اكو عده طرق، وايضا زرع الخلايا في المختبر. التكنيكس هاي كلها موجوده. الحقيقة الكيسات اللي سويناها طبعا عندنا الإيفا ستم اللي هي ويا مهندس زاخر اللي هي مسؤولة عن تصنيع بعض الأجهزة الجديدة والتقنيات الحديثة اللي سويناها. براءات الاختراع عندنا 5 براءات اختراع، 3 داخل العراق كلها ريجنريتيف ميديسن من 2001 2017 2017. الرابعة هذه في تركيا حصلناها، هسه نحكي على تفاصيلها. والخامسة أمريكية يو اس بيتنسي، هاي السنة حصلناها داخل البلد، تقنية جديدة لعلاج تنخر رأس عظم الفخذ. فإذا عندنا 5 براءات اختراع، عندنا 4 كلينيكال ترايلز 4 كلينيكال ترايلز. هذا الجهاز الجديد اللي نستخدمه انه نحول الدهون الى SVF. الSVF هو خليط من الخلايا المناعيه والخلايا الدهنيه وخلايا المناعه وغيرها. هاي تستخدم استخدامات متعدده. هذا الصنع في المانيا و in the way to be marketed. وهذا يعني احنا هذا فريق العمل اللي موجود داخل البلد. نشتغل في مستشفى ابن سينا، مستشفى اليرموك دكتور خليل، ومستشفى الزيتون ومستشفى يحيى. سجلنا 4 كلينيكال ترايلز امريكيه، يعني هذه هسه بها رقم US كلينيكال ترايلز. فاشتغلنا بابن سينا 60 حاله اوستيوارثرايتس، 30 كنترول، 30 احنا اشتغلناهم بالطريقه الجديده اللي هي بون مارو اسبريت كونسنتريت ان ذا تريتمنت اوف اوستيوارثرايتس. هسه نشوف النتائج كانت جدا مذهله. طبعا هاي واحده من الكلينيكال ترايلز. سجلنا كلينيكال ترايل اخرى. طبعا هذا الجريدنج مال اوستيوارثرايتس ما ندخل التفاصيل. ونجي الى طبعا هو ماك سكيل نستخدمه لمتابعه حاله المريض. هاي دكتور خليل التراسونيك جايدد انجكشن بمستشفى بن سينا. ايضا التراسونيك جايدنس. هذا قبل وهذا بعد. هذه فد شيء ما موجود، يعني انه احنا عندنا هذا جريد 4 اوستيوارثرايتس اللي فوق ورا العمليه. هذا دكتور خليل هذا سنه وثلاث اشهر، سنه وثلاث اشهر. تلاحظ human new chondrogenesis which is not يعني حقيقه ما لها اساس بالعالم. احنا يعني تعجبنا بالنتائج، وهاي سجلناها اكثر من كيس، يعني قدمناها ايضا مستشفى بن سينا. هسه نشوف يعني سجلنا 3 حالات من هالنوع. هذه بيفور وهاي افتر. طبعا واحدة من المريضات سويناها ورا 6 أسابيع جدتي قالت خلينا نسوي أشعة. سوينا الأشعة ولا new chondrogenesis which is something unusual حقيقة بكل العالم. يعني احنا ممكن نحصل تحسن بالوظيفة بالبين مانجمنت، بس هنا احنا عندنا new chondrogenesis يعني جريد 4 بعد ما تحتاج زرع تبديل مفصل وكذا خلاص. with this procedure which is not simple, it involves the use of bone marrow aspirate concentrate, and then you can inject it with a special needle which is also patented by our team. هذه ايضا الكيس الثالثه. 3 كيسات اللي هسه يعني متاكدين منها حقيقه باي راديولوجي مو بس بالهذا. فاوتولوجس MSCs superior to allogenic source. طبعا BMA versus SVF. البون مارو افضل بالنسبه للنخاع لان هو ميزوديرم وهذا ميزوديرم، فانت تستخدم البون مارو اسبريت كونسنتريت فور ذا اوستيوارثرايتس. ايضا سوينا كلينيكال ترايل اخرى سجلناها اللي هي هذا رقمها. استخدمنا اسلوب جديد نيو ابروتش اندر لوكال انستيزيا بدون تخدير عام include decompression without drilling and autologous bone marrow injection with a special needle. 10 حالات مسجله هاي. عندنا بالنسبه هاي النيدل الجديده اللي صنعناها واللي بيها ايضا براءه اختراع، و يعني من تدخل العظم حقيقه انا مسوي الاف الحالات بون مارو سبريت. هذه كلش سهله وبين يعني less pain than the usual. هنا هذا الجايدنس بالنسبه للافاسكولار هيب نكروسيس دكتور خليل. هذه احنا سوينا يعني راديولوجيكال بروف انه احنا بدنا نوصل للهيد اوف ذا فيمر بحالات الافاسكولار هيب نكروسيس. هاي قبل وبعد افاسكولار هيب نكروسيس. لاحظ وضوح النتائج. بالنسبه لل neuroprogenitors, we use the neuroprogenitors to inject for people with a spinal cord injury. حقيقة سوينا عدة كيسات and we are on the way for other cases. Autologous hip OA is high level of evidence حقيقة. يعني احنا نمشي سريع على مود الوقت يعني، ولا هي هواية تفاصيل حقيقة. انتم حاطين لي البرزنتيشن مال دكتور خليل، طبعا مو مالتي، اللي يعني intervertebral disc biologics طبعا احنا عندنا اضافه الى ذلك استخدمناه بالنيورولوجي، بالمالتيبل سكليروسيس كانت يعني مقالات عديده. هذه سباينال كورد انجري، مريض سباينال كورد انجري، سوينا له انجكشن اوف نيورال بروجينيتورز افتر برايمينج. intradiscal biomaterial injection. هذا الأزفية في الجو الأبيض هو الخلايا، يعني فعليا هذه اللي تستخلص من الدهون طبعا، واللي تستخدم استخدامات متعددة. هاي عندنا بال 2020 وقت الكورونا سويناها، وسوينا لها كلتشر بعدين بالمختبر. هذا التوميسنت سوليوشن اللي ينحقن بالبداية، وبعدين نسحب الدهون ونسوي لها هاي، نجمعها بباق، وبعدين نسوي لها التراسونيك اكستراكشن، ووراها البرودكت سنترفيوج التراسونيك. هاي الخلايا سوينا لها ماركينج with CD90 اللي هو مال ميزنكايمال ستيم سيلز، تاكدنا من عندها. وايضا عندنا ترايل اخر اللي هو على الانتيريور كروشيت ليجامنت تير، ايضا سجلنا كلينيكال ترايل امريكيه، بون مارو اسبريت كونسنتريت فور انتيريور كروشيت ليجامنت تير، 10 حالات. والكلاسيك تريتمنت كلش كوستي ونوت بيرمننت، وهذا اسهل هوايه الطريقه الجديده. اي for the ACL partial or complete ACL tear. الدرو سبيد عادة بون مارو اسبريشن كل ما تكون اسرع افضل، وعادة 10 سيسيات السحب لكل مرة بالنسبة للبون مارو. هاي مكررة. ايش قد مسوي سلايدات؟ هاي 100 اعتقد نختم. شكرا جزيلا.
Thank you very much, Dr. Abdel Majid, for conveying what is happening in Iraq, and it sure is amazing. وإن شاء الله نتمنى لك كل التوفيق. It is my pleasure now to introduce you to a distinguished speaker, Dr. Sahar Qazzaz, and a very dear friend. She's a plastic surgeon. She's the first plastic surgeon in Iraq since 1995, and the first in UAE since 1999, since she moved to the UAE. And she's a pioneer in the plastic surgery field. She now is working in Novomed and is also affiliated with the Bioscience Stem Cell Clinic and Laboratories in Dubai. And she is the only DHA, which is the Dubai Healthcare Authority licensed plastic surgeon to transfer or use stem cell therapy in her field. So please join me in welcoming Dr. Sahar Qazzaz.
Assalamu alaikum. Good afternoon. First, I would like to thank the organizing committee for this interesting meeting. I'm a plastic surgeon, and we will talk about the application of stem cells in clinical practice. Why it is important, the fat. We are only using, I'm talking only not the bone marrow. On the great job of the doctor, it's amazing. You have no idea how much this is amazing, the result. But usually in the bone is very good bone marrow, but for us, we are dealing with the skin. This is the organ that we deal with it as a plastic surgeon, is the skin and subcutaneous tissue, muscle, sometimes bone in maxillofacial and the lower limb. But the skin and subcutaneous tissue, the fat, is our major organ we're dealing with. We are very excited that when they discovered it in California researcher, in 2001 that there is a mesenchymal stem cells in the fat. Before, mostly was used in the practice, medical practice, regenerative, only from the bone marrow or from the cord blood. But 2001, we discovered that the richest organ in the body that contains the stem cells, mesenchymal stem cells, is the fat. It's not important also availability, abundance, easy to get it, but also it's a weak immunogenicity, which is very important, and also its highest ability for renewal or differentiation. It has the ability of homing, that it go to the damaged tissue with important things. Its ability, as we said in autocrine, paracrine, and we talk about it, how much this is important. It is available, yes. Each 1 gram of fat cell can give us between 5,000 ila 1 million. And we can see there is a big difference in the number because different from which area in the body, even superficial layer to deep layer of the abdomen is give different number. The age of the patient is very important, and there is many factors. But important, if we compare it to the bone marrow, each 50 cell of fat cell can give us 1 stem cell. If we compare it with the bone marrow, each 10,000 to 100,000, it gives us 1 stem cells. That means how much large sources that we can get, especially when we know that 65% of our body is a fat cell. Don't tell me there is obese, there is thin people. Obese and thin, they have the same number of fat cell. A fat cell not increase in the number except in morbid obesity. And also that means we can get the 1,000 times stem cells compared to the bone marrow and compared to the cord blood. That means it is the richest sources of the stem cells in our body. For that, this is since 2001, all the study and researches started to about collecting the fat from stem cells from the fat, and we see large, huge number of study in regenerative medicine. Important is it is similar to the bone marrow, but not identical. They are sister, but they are not a twin. The specification also is important. From the fat, it's higher proliferation, 40 times more than the bone marrow. Lifespan is very important, is a longer. Shorter doubling time, this is very important. When we culture it, to get specific number of stem cells, we need half time with stem cells, mesenchymal stem cells from the fat or from the other part of the body, whether bone marrow or cord blood. And also, now because it's very important, we are talking about the stem cell therapy, which is acellular. Now we are talking about the bioactive molecule that we are collecting from stem cells, and there is a huge number now started in research, especially last 5 years, and all of you, maybe you heard about the oxazome, about the peptide, about the condensed media. These are the number of it, the released bioactive of number and the variety from the stem cells of mesenchymal stem cells from the fat is wider than the one from the bone marrow. The first group, as we said, the researcher in California, and those the one who they started. The only disadvantage they are talking about it compared to the bone marrow in the old days is that we can use it only autologous, not can use it allogenous. And this is not anymore because the last few years we started to give it even myself. I received 2023. I received 200 million from young people less than 25, mixed it with Wharton gel, 200 million. And last year I received 100 million with no any complication, very safe. I received it IV, not only myself and even my brother, because he's diabetic. So now we can use it not only, is this not anymore allogenic, we can use it also anogenic. The other things is a relation with the cancer. Till today, there is no study correlated the mesenchymal stem cell from the fat with cancer. But where is the caring everybody that the obesity is correlated with the cancer? So as they say, the obesity related to the cancer means the mesenchymal stem cell from the fat, it will be correlated. احنا عادة نقول بريء حتى تثبت إدانته. هنا هي مدانة لأن ما تثبت براءتها. But there is no study. The biggest study they done it in plastic surgery when we done reconstruction after mastectomy. When we enrich the fat with mesenchymal stem cell, there is 2 major studies. One in Japan, they done large number of patients. They follow for 7-9 years. No one case recorded of recurrence. And the other study done in Brazil for 3 years. They follow them. No case recorded recurrence of malignancy after injecting using the fat for reconstruction, which is enriched with the stem cells. So till today, there is no one case recorded, but nobody can say there is no relation because the obesity related to the cancer. So in practice, how I'm myself using the stem cells. When we take the fat from the patient, what I would do with it, either I use it as a cell or cell-free. When I use it as a cell, either I culture it, send it to the bioscience, which is in DHCC. They extracted the mesenchymal stem cell, depending on CD marker, and then they culture it and expand it and return it to me in 3 to 4 weeks, and the number according to the what therapy I'm using it. The other ones, I'm the one who made it in the OT. This is, we call it ready use because we do it, prepare it in 2 hours, then it will be ready so I can use it. How we prepare it, either by using the enzyme or using a mechanical preparation. So let us talk now about the cell-based mesenchymal, how we use it. Either I take it directly, inject it to the patient according to the therapy for rejuvenation, for hair, for scar, for wounds, for chronic ulcer. We use it. Or we mix it with the fat and we inject it. The culture is the same. Either we use it directly like hair treatment, rejuvenation, head rejuvenation, or we mix it with the fat, make the poor stem cell fat to rich stem cell fat, and we inject it to the patient. And there is many difference between the SVF. We can quickly collect it. When I have patients, she coming from outside UAE, she coming for the treatment. I have no time to wait for 4 weeks, so we go to the SVF. A patient we want less cost of that, we go to the SVF. But practically, I'm using an SVF when the number is not important. There is cases I don't need 100 million of stem cells. When the cases I know, the number is a matter, I send it to the bioscience to get a culture and expand it, and I need more specific mesenchymal stem cells. The important things to know for us here is regulatory. We are in the UAE, it's opposite. Usually, enzymatic, mechanical, get an approval before. Here in the Dubai, bioscience, they get the approval as a culture and expand it. And when they receive the approval, only for a plastic surgeon. Yes, the orthopedic, they are using it, but without, let us say, under the cover, is not by approved, but they are using it. But who legally approved is only the plastic surgeon and the dermatologist. So this is regarding, but later now, since 2018-19, we are the only hospital till today, maybe tomorrow there, we approved from DHA to prepare a mesenchymal stem cell, which we call stromal vascular fraction in the OT and give it to the patient. As we know also, SVF is not storage. When we prepare it, we have to use it. While the culture and expand it, they keep backup for the patient. Anytime we can order it and expand it, as the patient pay for the packing of the stem cells. So SVF, we not talk about it. Let us say how much number we can get. We can get 500 to 1 million, should be. The important is viability. The viability, as it is more than 70%, it will be helpful. Maximum we can 6 million, but this is not the right. Now I have many patients when they are younger age. I can prepare for them even up to 15 million mesenchymal stem cell if the patient is young. So this one I will not go to detail of it because cell identity is very important to know what we are using. Stromal vascular fracture, we cannot say all of it is stem cells. Only 15% of it is mesenchymal stem cells, and there is other cell with it. There are many studies in neurology discover that SVF sometimes more effective than the culture because the other cell sometimes supporting the mesenchymal stem cell. This is a big science. We are till now, we don't have a real guideline. We just observe. For that, most of the study you see it is a case report, case series, short cases, comparative. We don't have level 1 study, they are very limited in the number. So still we are just observing. Sometimes SVF more effective, sometimes culture more is effective. So how we prepare it? Usually when we see here, it is enzymatic, the first team who discovered the mesenchymal SVF, they use the enzymatic. The enzymatic give us larger number of cell, need a bit longer time, but doesn't matter. The effectivity is 1,000 more. If you ask me if you have something can give you 1,000 more effective, why you use the mechanical? Because in mechanical, we can easily get the approval from the health authority in any country. For us in the UAE, in 2016, we don't have enzymatic approval. I use the mechanical for my patient. But since we get an approval for enzymatic, usually I stop using the mechanical, I'm using the enzymatic. Why the enzymatic is need more difficult in approval? Because we use enzyme. There is a manipulation in the tissue. It's put it under the category of the drug. They put it under a class 1 category of manipulation of the tissue, while the culture, they put it even in the class 2. The mechanical is something like PRP, but a little more. Even when I started in the UAE, they're not allowed to say the company we are selling SVF machine. They say we are selling to you cell therapy machine. And this is, we talked about it. The culture and expanded. This is how much important is the day, then we can get the number that we want. But usually this is from bioscience themselves. But we don't expect we get this large number in 12 days. This only in young people. In older people, we need 3-4 weeks. How we use it in plastic surgery? Either we inject it directly, like in a burn, like in tissue regeneration, in acute, chronic wound, or sometimes for the scar we use it, or hair restoration, or sometimes rejuvenation, or important for me in my practice is mixing with the fat. When we mix it with the fat, we can solve many problems. We know all over the world we have a lot of deformity in the contour of the body due to the accident, due congenital, due to the tumor excision, so due to the chronic ulcer, bed sores, whatever. We need some time to correct the deformity, breast congenital anomaly, buttock anomaly. These need to mix it with the fat, because this usually the tissue is very poor in blood supply. If we put only the fat, it will not survive. So need the stem cells to give us better quality fat, injected fat. What level, as doctor talked to us before, thanks for him, there is a lot of level of evidence. So I will make it short. In wound, acute, chronic, in any application, in plastic surgery, we know it is work. There is no single study. You can read or search all the internet. You cannot find any study, comparative, not say at the end it is work. But the problem that it is a drug, we know it is work, but we don't know how to use it. We don't know what is the dose, how many million I should inject, how frequent I should inject. Each therapist, each surgeon use their own protocol because it's a new science. Myself, I'm prepared, I injected, I'm observer. I'm using stem cells since 2015. Till now, I'm observing. Even sometimes they tell me that it's not gonna work. It is work always. But it's different because the patient itself is different. Age, medical problem, genetics. So no need to think about it is work or not, it is work. In wound healing, we know how much it is important. Accelerated wound healing, burn is very important due to the effect of it is through the immunomodulation, very important. Differentiation, also the most important factor is angiogenesis of it. And besides, now we know the paracrine effect of it is very important also. So how we use it? Either we directly inject it sometime when it is without fat, or we use a scaffold. When we use a scaffold to maintain it in the area that we want it. And I can show you, this is one of my patients. This case, she is congenital anomaly of the breast, and if anyone who knows the tuberous breast, part of the anomaly is she has herniation of the nipple areolar complex. This is patient, very young and mullet. And unfortunately, after surgery, I was shocked with this one. Then she will have asymmetry. Any plastic surgeon, they say the nipple areolar is a forgiving tissue, it will heal. Yes, it will heal, but she got asymmetry between the two sides. Its size, its shape will be a problem for a very young lady unmarried to get it. So it's come in my mind, at that time I was using a mechanical preparation of SVF. I never use it for a breast or any, just in the wound healing. I say, okay, I have nothing to do, I need to try. So what I done, I prepared for her here a platelet-rich fibrin. I done for her PRP, but it wasn't that helpful. So I said, let me try something new. I prepared this fibrin, which is from the PRP, from the blood. Then I put mechanical prepared SVF. If you ask any plastic surgeon, he tell you impossible. This give you very normal nipple area complex. Later we done for her scar revision, we improve it. This is in the history of a plastic because any problem in the nipple areola, it will never give you pigmented nipple areola. Always ended with apigmented. To get the color of nipple areolar complex in a patient, originally she is congenital anomaly. This is a result, we cannot get it unless we do something in new. This is in new, this is magic treatment, is the stromal vascular fracture, SVF, we prepare it mechanically. So the number is not important. Mechanical give us low number, but in such cases, it solves a big problem. Also, when put it with skin graft, it can help. We know that the chronic wound problem is in the medicine. It is the most costly problem all over the world. $billions of dollars is spent all the world from the diabetic ulcer, venous ulcer, traumatic ulcer, delay wound healing. So we need something new. The something new that we are using, and we all study its help. There is no doubt about it. But as we said, we don't know the dose. This patient, unfortunately, he's my brother. He's living in Turkey. Suddenly, I discovered that he's diabetic, that he has a chronic osteomyelitis. He never talk about it. Always is talking. Nobody want to see it. He done a skin graft before it with this contracture, and he has osteomyelitis for a few months. I just let him fly to Dubai. I have no time to prepare culture. I used for him SVF. Everybody told me SVF from diabetic patient is not work. I have no other choice. I need to do something before he fly back. I prepare SVF from him, and it was a viability 79 that time, and even power 7, about 15% of the SVF, about mesenchymal stem cell, I injected. In a few weeks before even he come for IV injection, already it's healed. I can see here osteomyelitis. And even you can see the scar itself, a contracture from a previous skin graft. He done it in Turkey. Can you see how much it improved by injecting fat? This fat is mixed with the stromal vascular fraction of diabetic patient. Then after that, I start to search on the internet, and I found very interesting study that a diabetic patient still can give us healthy stromal vascular fraction. So if you use diabetic patient, just control hemoglobin A1C, make it less than 6.5, then you will get healthy stromal vascular fraction. Interesting for using it is in radiation. The problem with the radiation, radiotherapy itself, it's a switch off the function of stem cells that is in the recipient area. Yani if this patient gets radiation, what will happen with her? All the fat tissue in the surrounding, the stem cells in it, natural as stem cells in it is not working. It is switched off due to the effect of radiation. All what you need, just inject even fat alone. In many studies, they said even injecting fat alone, it will switch on the function of the stem cells that naturally available in the fatty tissue around there. So if you inject it even with SVF or with culture, you will get even better results. So the only solution for chronic ulcer post-radiation is inject the fat, and even better if you enrich your fat with the stem cells, mesenchymal stem cells. With this scar, all the study, it say it's helped. All the study, no doubt about it. This is one very interesting patient. She is pharmacist. She's medical rep of one of the company. She is very educated. 8 years. She tried all modality of a treatment. She used to work, she's Egyptian, she used to work in Kuwait. She tried all the in the plastic surgery, laser, excision, Kina cord, many sessions. Nothing can help. 8 years, she is complaining from continuous itching and pain. So I told her, see, we have nothing. You are pharmacist. Let us do something experimental. And she was very cooperative, to be honest. We prepared culture stem cells in bioscience, and what we did, I did a 3-part. One of them, I done excision and injecting SVF. Not SVF, it was culture stem cells, and here the number of it that we prepared it. Then I here injected directly in the keloid. I done nothing, just injected. Here the interesting, what I did, here I inject fat enriched with stem cells. Excision injecting only stem cells, no excision, injecting fat enriched. The best result we get is not the excision. When we mix it with the fat cell, Till now, many studies, they said, even in a treatment of hair loss and alopecia, we got a good result when we mix the stem cells with the fat. If you ask me why, we don't know. There is something, there's some key, till now we don't know it. Why we get better result when we keep the stem cells with the fat. So here the only ones that the pain and itching disappear in this third. This is patient, she is Spanish, she flew from Spain, she read about the stem cells, she here at Dubai there is stem cells. This patient, she suffered car accident done by her husband, okay, and she entered about 7, 8, many free flap failed. The problem that she end here with scar tissue that above the medulla, not even above the periosteum. Her leg here, you can see, it's very painful, the screw here. Nobody can even move a sheet on her leg, always in severe pain and tenderness. We done 3 sessions for her on a 3 visit to Dubai. I injected the SVF, and I also mixed it with the fat and injected. This is very interesting, but this is a video, and we have no time. I can show you. In the video, I can easily move my hand all over her leg, very comfortable, no any more pain, and also the tissue is supple and not anymore attached. Here, there is two indications we use it. Here now I will talk about the scar. You see, this child, she has a congenital hygroma, a tumor excised from the arm, axilla, and side of the breast. When she was 1 year old, and with deformity of the breast, and you see any plastic surgeon, we know this is contracture in the axilla. If you ask any plastic surgeon, he say we need to do multiple zetoplasty or local flap rotation. All what I done is I done incision of the scar, subcision of it, I cut it in pieces, and I inject fat mixed with culture stem cells. I mix it with the culture stem cells and I inject it.
Dr.
And I was able
3
to
more
release,
minutes, please. 3 more minutes, please.
Okay, inject it and we solve the problem. It's work also for acne. We can see this patient by patient, we not use any tightening technology. There is no laser, nor there is no RF. In 2011, I put only fat. 2020, I inject the stem cell culture expanded in her hair and in her face. You can see 2021, she looked 10 years younger than she was in 20. All the study, we know it's work. We have no doubt it's very good for skin rejuvenation, improving the quality, hydration, and the dermal thickness of the skin by stem cells. This is my cases. I'm the only, started by myself, using for hidradenitis suppurativa. I have many successful, no recurrence. Then I start to search the internet. Am I the first one? I found no. There is in Spain and there is in another country. They are using, now still under a trial, comparative study, but they are not using it only for hidradenitis. They collected many cases, many other skin lesions. To use mesenchymal SVF for treatment of hidradenitis suppurativa. We use it, mix it with the fat, is one very amazing indication. We can see this hemifacial atrophy. We solve it by, because this is very difficult, he has also the acne, so acne usually if we put just fat, will not get the same result because he have a lot of fibrosis. So I mix it with the SVF and only 1 session we solve the problem of hemifacial atrophy. For tear trough deformity, we can see this is very young age, a lot of improvement. My part, mostly I using it in the breast. A lot of patients I'm using mesenchymal stem cell for the breast. This is a tuberous breast, 2 sessions. Only the first session I injected with the stem cells. The asymmetry of the breast, 1 session we corrected the asymmetry. This is the same patient, but here we are showing how we solve that, the deformity in the breast. And this is one of the most challenging cases. This patient, she done in Canada. They put for her 600 implant. She got this problem. Then her surgeon take her to the OT again. She put for her IDM. Then she cannot live with this large size implant. She went to the US. They told her we need to the skin sparing, nipple sparing mastectomy. Your breast will never survive if we remove the implant and do lifting again. So I told her the only solution that we need to put the fat, and fat will not survive. We need something to improve the vascularity of the tissue. So we done enrich it with stromal vascular fraction. Thanks God we did it without any complication. We solved the problem. of the implant, and I'm using a lot for treatment complication of a breast implant. And this is not my patient, this is from the bioscience. We can see even in MRI where we remove the implant, الفاف can't be survived. This is one of the difficulties. You say, okay, any fat can put it, we get this result. No, not any fat. Here we have a lot of
Dr.
fibrosis
Sahar?
due to the superficial liposuction.
We need to end the talk, unfortunately.
That's fine. Okay,
Yeah.
Habibi. Thank you very much for listening.
Thank you. Thank you very much, Dr. Sahar, for the wonderful talk. And I know that you have a long experience as a plastic surgeon in the field and pioneer. It is now my pleasure to have Dr. Mohammed Jumaili join us for this session. And he's a neurosurgeon and also a pioneer in the regenerative medicine. He will talk about spinal injury and innovative ways to treat it. He's currently working as a American Spine Hospital, and yeah, we are looking forward to your talk. تفضل.
Assalamu alaikum. Hello, everyone, and thank you for inviting me to this conference. Spinal cord injury has been a very challenging subject to treat over the years. It has been known for a long time, since antiquity, where people have been affected by different types of trauma that has caused them severe debilitation. Now, this could be as part of war injuries, where we can have a bullet that could affect the spinal cord, or it could be as a sort of a criminal act, where we have like direct injury to the spinal cord, or as a result of road traffic accident. Now, the spinal cord is a very sensitive subject, and the issue is that also the vascularity of the spinal cord is very, very detrimental. So anything that could affect the spinal cord could cause severe debilitation to the patient and could end up with paralysis of the patient from the site of the injury and forward. Now, this is very important here, is that the spinal cord injury could be divided into two stages. There's the acute stage and there's this chronic stage. I think we have laser here. Let's see what works. So the acute stage is where we have the point of impact by the offending object, and then we have the chronic stage where we have a lot of necrosis developing, cystic changes, and we have Wallerian degeneration happening at the site of the impact. So just to understand this lecture a bit more into details, we have the impact of the spinal cord is divided into what we call the ASIA impairment scale, where A is complete injury and E is a normal person. So in the next few slides, so you will be able to understand how much improvement that the patient will get from ranging from A down to E. Another important thing that I'd like to mention here is that the pathophysiology of the spinal cord injury happens into two main phases. The phase one is the mechanical damage from the trauma. That happens at the time of the injury. Following that, we have a secondary mechanism which happens over the hours, days, and weeks following the spinal cord injury that results in the debilitating effect of that kind of trauma. And these injuries of the secondary mechanism are a lot, but the most important part of this is due to inflammation. So inflammation is one of the major causes of spinal cord injury. Now, this is an injury cascade that starts with interleukin 1 beta, interleukin 6, and tumor necrosis factor as the main offending inflammatory cytokines that are involved in spinal cord injury. And this is a very important point that I'd like you to take out of this lecture, is that the large-scale inflammatory response is the key factor in neural degeneration in spinal cord injury. So if we see this is the cross-section of the spinal cord, if we see that the site of the mechanical injury is pointed in red, we can see how big is the impact caused by the inflammation. So inflammation is one of the main important factors causing spinal cord injury and its debilitating consequences. So what happens when we have a spinal cord injury? We have an immune system that is disrupted, causing significant systematic decrease in immune function with alteration in macrophages, T and B cells, and natural killer cells. And this is a very important factor, because if you imagine, when you have a disruption of the inflammation, you will have less impact, as the body is trying to protect the spinal cord. At the time of the injury, if you have a full-scale immunological reaction, the body will actually kill or reduce the impact on the spinal cord. So this is a very important point. So the body is trying to reduce the impact of our immunity on the spinal cord. We have a disruption of blood-brain barrier and spine parenchyma, which exposes the adaptive immune system, including B and T lymphocytes, to the CNS. So it's just like we have antigens that have not been exposed to the blood for a long time, and suddenly they're exposed to the blood, so you'll have an immunological reaction. So that's why the body tries to shut down the immunological reaction, and that is one of the causes for which we have a lot of infection causing the mortality in spinal cord injuries, whether UTI, chest infection, blood scars, and everything. So these are important things that we need to keep in mind. And the neuroinflammation is mediated by cytokines and chemokines released by the astrocyte, microglia, endothelial cells, and periphery-derived immune cells. And going back again, the primary insult is a critical factor in determining the magnitude of the neuroinflammation. So as we see here in this slide, we have in the first few days after the spinal cord injury, we have a rise in neutrophils, followed by a rise in microglia and lymphocytes later on. The current treatments that we have actually are very limited in recovering any form of functional recovery to the patient, unfortunately. So what we do is we do a spinal decompression and fixation, and the recent study actually have shown that whether you decompress or not, it will not affect much the outcome, the functional outcome of the patient. So this is something very important. Steroids have been used, NSAIDs also have been used to reduce the inflammation that we mentioned is a key factor in this kind of trauma. Minocycline has also shown to provide some neuroprotective effect, as well as chondroitin sulfate proteoglycans. So all these have been used over the last decades to try and reduce the inflammation and improve the functional outcome. So where is the place of regenerative medicine in treating spinal cord injury? So stem cells or stem cell therapy can possibly regenerate the neurological networks and modulate neuroinflammation and ameliorate the damage. Well, the stem cells that we use are either mesenchymal stem cells, including adipose-derived, as Dr. Sahar was mentioning in her lecture, human neural stem cells, progenitor cells, autologous human Schwann cells, human umbilical cord-derived Wharton jelly, autologous bone marrow-derived mononuclear cells administered through multiple different routes. And these kinds of treatments with stem cells have three potential roles, is that they can provide cell replacement, stem cell regeneration, and functional motor potency. So these cells have got their roles to try and heal what's been happening to the spinal cord. So in this study, they utilized umbilical cord stem cells and transplanted to the site of the injury. So when they decompress the spine, they transplant the umbilical cord stem cells in the first 24 hours following the injury, and we can see that there has been an amelioration from AGA, which is complete, to AGC, which is like mid-grade. In the subacute phase, in this study, we see that using intraspinal bone marrow-derived mononuclear cells in patients with complete spinal cord injury, this was a two-branch trial. Some patients had it and some patients were controlled, and we found that there is 30% improvement in those who have had stem cell therapy in comparison to those who did not have, who did not improve. Here we have in human trials in which 70 patients were randomly divided into patients who've got stem cells and so those who do not have stem cells, and we found that 34% of patients who were treated with intrathecal bone marrow-derived mesenchymal stromal cell therapy demonstrated improvement in Asia grade compared to 0% in patients with a control group. In the study following that, we can see that in a group of 34 patients, AGA, so complete recovery, they were randomly divided into control group and rehabilitation group, and we have found that CT-guided implantation of umbilical cord stem cells in those patients showed significant improvement in motor, sensory, and urinary recovery prior to their treatment. Now, this is very important. As we know that spinal cord injury results in UTI, and UTI is one of the main causes of death in these patients. And that's why having a regain of the patient's ability to feel their bladder is of prime importance in treating their mortality. Now, what are the adverse effects of using stem cells? So it's not all sweet. There are some adverse effects that we need to put on our minds, and we need also to consent the patient, to tell the patient about these before we try and implement stem cell therapy for the patient. So fever, now this fever happens especially if you use if you use allogenic instead of autologous stem cells. Headache, this is if you do intrathecal, where there is increase in the pressure. Backache, the site of the intrathecal injection. Numbness, abdominal distension, neuropathic pain. Now, neuropathic pain, I just want to mention this quite importantly, is that neuropathic pain sometimes for us could mean that for us neuropathic pain is something annoying. However, believe me, for those patients who have spinal cord injury, only the fact that they're feeling pain is something very joyful to us because they are regaining their sensation. So something that is really, we don't care about it, we try and get rid of it. For them, is something, doctor, I'm feeling pain, neuropathic pain in my legs. I can feel my legs again because of the phantom pain that they could experience after their injury. Subarachnoid hemorrhage, very rare. CSF leaks from the site of the implantation, or transient deterioration in sensory motor neuron symptoms in case of implantation into the spinal cord.
5 more minutes, doctor.
Sorry. So for intraspinal approaches, we have found that the high level of engraftment and the dose also seems to be ranging from 1 million to 100 million. Exosomes have also now been introduced as a possible vehicle for stem cell for regenerative therapy, as actually there's a study that have shown that if you put extracellular, so exosomes into the IV administration, they have a better outcome for reaching the CNS more than the umbilical cord stem cells, and that's because of their size. Because their size, they can cross the blood-brain barrier. The route varies from intralesional to intravenous, but whatever the route you're trying to use, it is better that you use a higher concentration. Now, the future would probably be with extravesical vehicles, because basically you can, these are what we call the artificial exosome that we deliver ourselves. We can program them to be as more regenerative as possible before implanting them into the patient. Now, consenting is extremely important. When you have a patient who comes to you with spinal cord injury, do not, and I say do not, tell the patient you will walk away from here walking within the next few days. It's a long process. This is very, very important. So you have to tell them, first of all, you need to have a group of physiotherapists or rehabilitationists who can help you with this, because one hand does not clap. So you need a very good group, and you need to tell the patient that this is a long process. The most important, from my perspective, I think the most important, if you have a patient with spinal cord injury, you need to tell the patient that it will take 15 to 20 times for them to have good outcome. Now, for that particular reason, you need to give them stem cell therapy that does not cost much. This is very important. The issue is a lot of people go with very high doses, but high doses are very expensive, and very expensive means that the patient will not come to you for the second, third injection. You have to also do a lot of rehabilitation mentally to the patient to tell them that our main priority is to improve hand function, to improve sensation in the lower limb, to improve their abdominal sensation like menstrual cycle, urinate, defecate, sphincter control, reduce spasticity, improve muscle mass, and psychological support. You also need to prepare the grounds by giving them antioxidants and photobiomodulation, and the most important thing is rehabilitation, rehabilitation, rehabilitation. Just to tell you one case that we received. This patient was driving on a motorway. She fell asleep. She was hit by a car. She came to us completely paralyzed from the neck downwards. She's very young. She's got her own family. Now, when she came to us, she can just do like shrug her shoulders. Now, I can tell you that this patient, after starting the intense rehabilitation as well as stem cell therapy, so intense rehabilitation with stem cell therapy resulted that she was able to start using her hands, and then after that, to the degree now, I don't know, can we make this video work? Now she can actually stand up, and actually also she can start even moving her legs, and the rehabilitation, when they put a ball in front of her, she can actually walk on her knees. So what I'm saying here is that you need to consent your patients, have a good protocol in place, and make sure that the patient and all the team understand the benefit of what you're doing to them. Thank you very much.
Excellent. Thank you very much, Dr. Mohammed Jumaili, for this wonderful presentation. I will call the speakers for the certificate of appreciation. Dr. Yahya Kiwan. Dr. Sahar Qazzaz. Professor Mohammed Jumaili. All the speakers, feel free to ask them all questions later. You can approach them because of the time's sake. Thank you very much.